Je donne la parole à monsieur Fumet parce qu'il y a aussi un prix Dubois-Brigué dont il va nous présenter le lauréat, et puis la bourse et le prix seront remises en collaboration avec la Fondation.
Voilà, l'Académie a reçu 5 candidatures de haut niveau pour le prix Dubois-Brigué pour la pathologie tropicale 2014-2016. Et encore une fois, à l'unanimité, le jury a proposé d'attribuer ce prix au Dr Johan Van Griensven de la KUL pour l'ensemble de sa carrière, illustrée par le travail Clinical Research in Hard to Reach Context from Leishmaniasis in HIV Patient to Ebola. Le Dr Van Griensven a obtenu son PhD au Rega Institut of Leuven pour un travail sur l'approche génomique du traitement du SIDA. Il a également obtenu un master en épidémiologie à la London School of Hygiene and Tropical Medicine. Il a été lauréat d'un fellowship post-doctoral Baillet-Latour en 2008, et ce qui lui a permis de travailler de nombreuses années en Afrique, où il a contribué par une approche multidisciplinaire à établir un réseau de recherche clinique avec des plateformes laboratoires, à identifier les besoins en recherche opérationnelle de terrain dans le domaine du HIV, en particulier chez les patients exposés à la Leishmaniasis. Enfin, et c'est très important, durant l'épidémie d'Ebola, en 2014-2016, par son expérience et son leadership, il a coordonné un consortium prestigieux de recherche clinique en Afrique de l'Ouest, évaluant l'utilisation de plasma de convalescents comme traitement Ebola en Guinée. Voilà, j'invite le Dr Van Griensven à présenter son travail.
Merci beaucoup. Comme j'ai peur de ne pas bien pouvoir m'exprimer en français, j'aimerais faire le discours en anglais, si vous me permettez. So I would like first to focus on visceral leishmaniasis. It's a neglected disease caused by a parasite, Leishmania parasite. It's transmitted by sandflies. These sandflies transmit the parasite, which goes to the macrophages in the different tissues, goes to the liver, spleen, bone marrow. Patients develop fever, they develop pancytopenia, they have secondary infection, they go to a kind of immune deficiency, they start bleeding, and they die over the course of a couple of weeks without treatment. So you can see a couple of pictures here. It's one of the causes of massive splenomegaly. One of the issues with neglected diseases is that typically they occur in very remote settings, very complex settings, often conflict zone, poor areas. It's the same with visceral leishmaniasis, where we work. It's in East Africa. We work in Ethiopia, in the border regions with Sudan, Eritrea. Difficult to reach, sometimes unstable, also difficult to live there, to work. Temperature can reach 50%. So challenging context. Neglected diseases, it's one of the reasons why no one or very few actually conduct research on these diseases. So one of the first things we had to do was, like was mentioned, put together the right team of complementary expertise to function in these areas, to conduct clinical research according to high standards, international standards, having a clinical component, having a lab component. So we work there with different colleagues, different partners. One of them is Médecins Sans Frontières. As a neglected disease, very few people, organizations provide treatment for this condition, but MSF has a treatment program in these areas. We also linked up with Ethiopian colleagues, Ethiopian universities, and we also work with Drugs for Neglected Disease Initiative, which is an organization trying to develop drugs for neglected diseases. And then I worked, of course, with different colleagues in the institute. The focus of our research was then visceral leishmaniasis in HIV patients with a combined infection, because there is a very strong clinical interaction. If an HIV patient gets bitten by a sandfly, there's a very high risk he or she will develop visceral leishmaniasis. When you want to treat them, current treatments don't work most of the time. If they work, they will most likely come back after a couple of months with a new episode. They can have 10, if they survive, they can have 10 to 15 different episodes if they survive. But overall mortality is like, with treatment currently, 30 to 40%. So clinically, there's a very strong interaction, and we try to tackle different phases of this problem. The first was we worked on treatment, so we contributed to evaluation of a combination of different drugs, where actually success rate is very high. We go up to 95%. So that's the first step. Now we can treat the patients. We also evaluated a way to prevent the relapses, so the new episode after being cured. We also identified the treatment there. So both of these interventions will now be integrated, or are expected to be integrated in the latest WHO guidelines. And we also, and that's quite unique, we're trying to study the early phases of the infection. So when the patient gets infected, there's a period of a couple of months, 6 months to 9 months, before they actually get symptoms. And we're now trying to understand better what exactly happens and how we can prevent the evolution to disease. That's actually the most, prevention is always better than having to treat patients with drugs. So in this experience we gained, myself but also within team approach, to work in very difficult settings, but nevertheless always aiming to achieve high standards. I was also called upon to react during the Ebola outbreak, most recently started in 2014, where I was mentioned, I led a large international consortium to react very quickly and to put in place a clinical trial within a period of weeks to months, conduct research to evaluate the treatment for Ebola according to international standards, and we also achieved that, which I think was an important part of the Belgian contribution to the Ebola. With this, I would like to close the presentation, and I thank you all for your attention.